How's it going, Modern Manual Therapy viewers? Dr. E here, back with an MMT Q&A from Sally Superfan, Dr. Sally Moores of Artemis Physical Therapy. Sally asks, I have a patient with, when opening, her jaw shoots over to the left and then back to the center at end range. Her pain is on the left and the clicking is on the right. Her questions are, the first, what is the side of dysfunction? Can she have two? So let's address this first. The side of dysfunction often is diagnosed as the painful side, but it's not really as simple as that because the TMJ is one of the only areas in the body where both the left and right sides are one continuous bone. It is somewhat similar to the pelvis because there's a symphysis right here, and that allows for a little bit of independent movement, but overall, when the left side is moving, the right side is also moving. And if you're deviating to one side typically is not moving as much as the other side. So in this case, though, there's two traditional curves. I think they're inaptly named, but I'll go with the traditional TMJ nomenclature. The C curve is indicative of a hypomobility, which is the jaw with opening or mandible depression deviates away from midline, and it doesn't return to midline until it returns to full elevation. That's not what's going on here. That would be indicative of a hypomobility or some sort of potential non-reduction disc on the hypomobile side or subluxation that is not reduced. And it keeps on deviating away. So it's hypermobile on the left and hypermobile on the right. What's going on in this patient's case is what's considered an S curve, which actually looks like a C, where it deviates to the left, and then by the time it reaches end range, it goes back to the midline. So that would mean that there's some sort of potentially anterior subluxation of an intra-articular disc on the left, and after it reduces, it returns to midline. That is typically accompanied by an audible or palpable click, and you should hear or palpate a reciprocal click on the way back up, and you should see that similar kind of deviation away as it subluxes, and then return back to the midline on the way to full elevation. It's not always simple as that, and often, and I've seen hundreds if not thousands of TMJ cases over the years, where you don't really palpate the textbook or even auscultate the textbook reciprocal click. You may hear the initial reduction, but you don't typically hear the subluxation. It doesn't always make a sound. So can she have two? Absolutely. Essentially, if there's dysfunction on the left side, there has to be dysfunction on the right. And when one side is hypermobile, the other side is moving a bit too much, or it's hypermobile, typically an anterior translation. The hypermobility is usually there's a lack of rolling on both sides for the initial 50% of mandible depression. There should be rolling and then anterior translation after that if the jaw is moving straight. So just a caveat about moving straight too, there's, asymmetries in the skull, asymmetries in the way the jaw develops, and you don't always have to strive for full symmetry. I would always strive for function. You may find that when all function's restored and pain is gone, that they still deviate a little bit, and that's fine because it might just be their structure. All right. So the second question is, what would you address first? Soft tissue restriction or motor control? So in terms of that, I would address whichever one is going to help the patient the most. And I know that's always, it depends, but in general, I feel like manual therapy can assist these things along a bit faster by rather than only addressing merely motor control. So soft tissue restrictions or soft tissue tone, you can use light ISTM or inhibitory techniques along the masseter and temporalis. And sometimes that actually restores the ability for the mandible to go as straight as possible. And then you can do TMJ distractions or lateral glides on one side and medial glides on the other, depending on how they're moving. So initially, if they were deviating to the right, they would typically need a lateral glide on the right and a medial glide a lateral glide on the left and a medial glide on the right to get them to go straighter. One of the motor control strategies I use is active assistive mandible rolling. So the tongue should be at the roof of the mouth for the initial part of depression, and depress, and they can lightly posteriorly glide the mandible to restore that rolling phase. And also, if they happen to be deviating to the left initially, you could just put a one fingertip and teach them how to do this eventually on the right and have them push to the right. I had to make sure that they're doing it. And I was overcorrecting there because I needed to look in the video. And it's okay if they overcorrect because they need to start to learn how to fire initially their right lateral pterygoid and their left medial pterygoid to get that motion back. Because if you would manually muscle test, you'll find that someone who deviates to the left initially during depression is going to test strong with lateral excursion to the left and weak with lateral excursion to the right. So it just helps fire the right muscles in the right sequence. And one last thing in terms of the click. I think Sally was confused because the pain was on the left, but the click was on the right. And my question is always, is it a click or a clunk? In terms of click, that would be intra-articular, meaning it's a disc that is subluxing and reducing. It typically feels like a softer click to palpation. It also should sound softer. Versus a clunk is the eminentia articularis, which is a bone at the inferior portion of the temporalis. So that almost acts like a speed bump. During anterior translation, the mandible is not supposed to go beyond that. And when it goes beyond that, that's when you can have an open lockjaw. So typically, if the right side was clunking, if it was going too far anterior until it finally reduced at mid-range, you might actually be hitting the articular eminence on the right, which would be a clunk. Or you might be fooled by only palpating one side or the other. And this has certainly happened to me, where I was sort of confused, where patients said, my pain was on the left, but the click was on the right. And maybe even their x-rays showed that, or their MRI would show that they had a sublux disc at the mid or end range in terms of anterior translation. So what you may be fooled by is if you're palpating one side and you feel the click on that side, since the jaw again is one whole bone, it reverberates with the subluxation and dislocation. So you might actually feel that same click on both sides and somewhat equally because the jaw again just reverberates. It might not be that much weaker on the side that is not actually subluxing and reducing. So try to palpate both sides. You might be able to feel the click on both sides, or you might be fooled that the right side, non-painful, non-dysfunctional side is actually clunking because it's going too far anterior and hitting that articular eminence. So I hope this helps. I will also link to my five favorite exercises to show TMJ patients for home exercises. Make sure to subscribe via email so you don't miss out any of our amazing blog posts. Check us out, Modern Manual Therapy, on Facebook, Instagram, and YouTube. Please subscribe to those, like us, follow us, and share. We really appreciate all your support. Have a great day.